Hi guys, my name is Dylan. I am a pharmacy technician, and today I want to go over some of the most common antihypertensive medications that you'll see as a pharmacy technician, especially just entry level, working in retail. Wanted to cover some of the most common, and also go over just the most basic mechanisms of how they work. Just so it's good to know those things as a pharmacy technician. So, first, I just want to talk a little bit about hypertension itself. So, as you know, hypertension is high blood pressure. So, hyper and then tension. Um, and according to the CDC, approximately 47% of Americans have hypertension. And that's 116 million people. And hypertension can lead to all various sorts of illnesses and chronic conditions like heart attacks, which is also called a myocardial infarction. That's just the fancy medical way of saying it. Various cancers, strokes, etc. So we use antihypertensives because they're generally pretty cheap and they're a really good option when people, are starting to have the onset of hypertension. And these medications act in really, I'd say, four main ways. So, and we'll go over each of these ways in more depth as we go through the various classes of medications. Um, so, medications can reduce blood volume. They can dilate the vasculature or the arteries and veins and just your blood vessels. That's what your vasculature is. Blood vessels. Um, and then you can also block the RAS pathway, and we're going to talk about that before we get into those medications. Or you can reduce sympathetic nervous system effects, and we'll go over that as well. So first, I think that where we should start is just getting some terminology out of the way. So you're going to see this a lot in pharmacy, the difference between an antagonist and an agonist. So an antagonist, so right here we have, our cell. Here's our cell wall. And then here we have these two channels. So basically, say that X chemical, let's make it, I don't know, that. So let's say this like lime triangle is whatever chemical. This is all just made up just for the purpose of, the example. So say we want to open up this channel right here. Okay. So how are we going to do that? So let's say X chemical can bind to this channel and it like fits perfectly, and then it causes this channel to open, and then whatever the channel does totally depends on what we're talking about, but this is just how almost everything in our body works this way. So we have some chemical that opens up a channel or activates some metabolic pathway. So what an antagonist does is it blocks the chemical. And it can do this in various ways. So there's like competitive versus allosteric. But for that, it's not really important for this. And I don't want to get bogged down in advanced terminology when we're just kind of introducing the basics. So an antagonist, let's say that this pink square here, let's say that is the antagonist chemical. So what the antagonist is going to do is let's see, let me just redraw this receptor here. The antagonist chemical is actually going to bind and it's going to block the other chemical. So the chemical cannot reach the receptor, and that's because the antagonist is blocking it. And then you have agonists. So an agonist is something that imitates the chemical. So whereas the antagonist just straight up blocks the channel and does not activate the effect, the let's say this is the agonist, it can bind here, and even though it's not the same as our X chemical, it still can produce the same effect. So like let's say you just don't have enough X chemical to produce the effect of opening the channel. So sometimes we have medications that act as agonists. So it will still open the channel for whatever, maybe some ions go through here or something, but agonists will reproduce the effect of whatever chemical. So this is really important to know in future, because lots of things are antagonists or agonists. And so you'll also hear an antagonist called a blocker. Same thing, basically. So now that we got that out of the way, we can kind of start with the two most popular blood pressure medications. So our first class of medication are called angiotensin-converting enzyme inhibitors. Now that is a really long string of words. So let's just break it down. So angiotensin is a chemical in the RAAS pathway. So this RAAS, or just RAS, that's how it's referred to, is renin, angiotensin, aldosterone system. So I'm not going to go into the super specifics because this system is, pretty complicated. But suffice to say, what's important about this is that the RAS system is how our body raises our blood pressure. So it's basically a long pathway of chemicals interacting with each other to increase blood pressure. And it does this through various ways. So it's not just like one way. It kind of works in all parts of the body in all different ways. But most important is it raises blood pressure through various means. So as you can imagine, if we're trying to prevent high blood pressure, one of the best ways or easiest ways to do that is to block some part of this RAS system. So what angiotensin converting enzyme does is, in the RAS pathway, I'm not going to show the whole pathway, so I'm just going to start with angiotensin 1. So angiotensin 1, so let's say you have low blood pressure for whatever reason, and your body's like, oh my gosh, okay, got to raise the blood pressure. So you have angiotensin 1 that's released or created. So then, but this is not active. It's not doing anything on its own. So what happens is it has to be converted to angiotensin 2. And this is the active form of angiotensin. So what an ACE inhibitor does is the process of getting from angiotensin 1 to angiotensin 2 is done by this enzyme, as you can imagine, called angiotensin-converting enzyme. And I just said ACE here, so I just represent that with like a ball. And so the enzyme is what allows this process. So what an ACE inhibitor is going to do is it is going to prevent this process from occurring. So it's going to inhibit the angiotensin converting enzyme. And so this means that angiotensin 2 cannot be created, which means that blood pressure cannot go up. So that is the basics of how it works. And this is one of the most prescribed blood pressure meds. You're going to see it a ton in retail pharmacy. And so these include meds like lisinopril, which is also called Zestril. We have ramipril, which is called Altase. We have captopril, which is called Capitan. And another common one is enalapril. And this is called Vasotec. And so I'm sure you've already noticed that these all end in pril. So commonly these ACE inhibitors will end in pril. So that's a really good identifying marker of an ACE inhibitor, and it's pretty there's not many deviations from it. So it's a really good indicator. And then something interesting to know that is a common question for PTCB exams is ACE. I'm just going to say ACE-I. ACE inhibitors can cause dry cough. And I mention this just because it is such a common symptom, and it's often the reason that people get off of ACE inhibitors. It's just a very common thing. And so it's just good knowledge to know that it's just a common reason that people get off of it and switch to one of the other meds that we're going to talk about. But ACE inhibitors are generally like some of the first line blood pressure medications we use. Let's see. So now let's talk about angiotensin receptor blockers. So now we're still using or still interacting with the RAS pathway. But we're doing it at a different place. So in this, what's going to happen is, we go from angiotensin 1 to angiotensin 2. So that still happens. But now, so let's say we have a cell here. So let's just say this is an angiotensin receptor on one of your body's cells. So normally angiotensin 2 would come in here and boom, and then once you're linked to the cell or the receptor, then you can produce, the effects, the various mechanisms to increase blood pressure. But a angiotensin receptor blocker, also called an ARB, is going to block this, which means that angiotensin 2 cannot bind, which means that no increase in blood pressure. So it's just a different part in the RAS pathway that we're affecting. And so some common ARBs are going to be things like losartan, also called Cozar, irbesartan, it's called Avapro, and these are brand names, by the way. So sometimes you'll see them. Sometimes people get brand names for whatever reason. Sometimes they just feel like it works better for them, or maybe their insurance prefers it for whatever reason. But most commonly for blood pressure medications, you're just going to see the generic name. We also have olmesartan, which is Benicar. Telmisartan, which is Micardis. And finally, another common one is valsartan, which is Diovan. So as you can see here, all of these end with artan. So very important. That's a good way to identify an angiotensin receptor blocker. Okay. Now on to calcium channel blockers. So basically, let's say we have let's say that this is a myocyte, which is a muscle cell. And we can use more specifically a cardiac, so a heart muscle cell. So basically, let's get this correct here. So basically, when the heart contracts, it needs a bunch of different ions to perform the contraction to, pump the heart. But one really important one for the actual contraction is calcium, which you'll often see shown as Ca2+. So calcium is for reasons I won't go into, more calcium equals harder contractions of the heart. And so we can exploit this by blocking calcium's flow into heart cells. So So what a calcium channel blocker, or a CCB, does is it's going to plug up that hole so that calcium cannot enter the cardiac cell. And so effectively, this is going to reduce force of contractions. So if your heart's not beating as hard, if you think of it like a pump, if it's not beating as hard, it's not creating as much pressure. That's like the easiest way to think of it. When you have like a hose and you just have it on just a little bit, there's not a lot of pressure because the pump or whatever is not going at full force. So reduced force of contractions means lower blood pressure in the end. So let me get all this out of the way. So some common calcium channel blockers are going to be things like amlodipine, also called Norvasc. We have nifedipine, which is called Plendil. We have diltiazem, which is called Cardizem. And finally, another common one you might see is verapamil, which is also called Verilin. So this one is not as easy with like the endings. You can see that sometimes they'll end in dipine, but not always. So I wouldn't, it's not like a hard and fast rule. Most common, I would say, is amlodipine. We see amlodipine a ton in the pharmacy. That's one of like the most common medications I see in a daily basis. So it's good to know. So then for these next class of drugs, first we need to talk about alpha and beta receptors. And to start, let's just start with talking about your fight or flight response. So I want you to think of like a time when you were really stressed or your heart was pumping really fast and you felt maybe like you felt in danger, or you just wanted to leave somewhere, you were just not having it, and you experienced your fight or flight response. So in medicine, this is called the sympathetic response. And so when you have your fight or flight response activated, you have two chemicals that are released. You have epinephrine, which is also called sometimes adrenaline, and norepinephrine, sometimes called noradrenaline. So in your fight or flight response, epinephrine and norepinephrine are the two chemicals that are going to elicit that response. When your heart starts beating fast, you start sweating, your mouth gets really dry. And that's all on purpose. That's what the body wants, because in a fight or flight situation, you want certain things, certain body systems to not really be active. Like, for example, the reason your mouth gets dry is because when you're in your fight or flight response, you're not planning on eating, you're planning on running away. So you would rather focus that energy on somewhere else. So all we say like your secretions become dry, like your mucous membranes become dry because you're not planning on doing any eating, no digestion. You got to survive. So all your energy and your blood goes to your muscles and your heart, and that's why you have a lot more endurance when you're scared shitless. So now that we have that out of the way, so it's epinephrine and norepinephrine. But like I said, it's not going to act the same way in all parts of your body. So epinephrine and norepinephrine, even though they're just the same or there's just two chemicals doing all this work, depending on the receptor it binds to, it will create a different response. And this is super important to know because there are a lot of questions about how epinephrine and norepinephrine interact, because a lot of drugs target these systems. This is also called, another really good thing to know, this system is called the adrenergic system. And just remember, adrenaline, adrenergic. So basically you have alpha and beta receptors. So these, depending on the receptor that's having epinephrine bound to it, it will elicit a different response. So I always come up with this, I always think of this handy mnemonic. A, B, C, D. So alpha and beta. So that's the A and B part. But I just think of it hopping over 1. So alpha contracts, beta dilates. This is super useful because I can't keep track of, I can't think instinctively sometimes, especially when I first started, about what alpha and beta receptors did. But once you think alpha contracts and beta dilates. So for example, if you have an alpha agonist, what is an alpha agonist going to do? So it's going to imitate epinephrine or norepinephrine binding to an alpha receptor, which means a contraction or constriction. I should actually say more specifically constriction, like when we're talking about blood vessels. So yeah, an alpha agonist is going to constrict, like a drug like an alpha agonist. And another good thing to remember is that because these alpha and beta receptors are further broken down into alpha 1 and alpha 2, and then beta 1 and beta 2. There are other, you can break this down even further, but that's not really in the purview of this video, I don't think. So a really good way to remember these subdivisions of 1 and 2 is you have 1 heart but 2 lungs. So the 2s will be found in places like your lungs, and then the 1s are found in your heart. So this is really good because some drugs are selective to one receptor. Like it will make some drugs are very specific to just beta 1, which means it'll only affect beta receptors in the heart. But some other medications just act on all beta receptors, so it would affect heart and lungs. So some drugs are selective and some are not. So that's a really good thing to know. So I want to pull this all together and give you an example. I want to give the example. Let me get some stuff out of here. I'm just going to erase this just so I can... you can always go back in the video and see. Let's choose... I'm just trying to get the right color. So, for example, this is not a blood pressure medication, but I just want to give an example of, to put what you're learning into context. So I want to talk about albuterol. So albuterol is a rescue inhaler that people use for things like asthma. And so albuterol is a beta 2 agonist. Okay, so let's break that down. So beta, which means that it's going to dilate. 2 means it's in the lungs, because 2 lungs. And agonist, which means that it is going to impersonate, or it's going to mimic the effect. It is going to mimic the effect. So albuterol will dilate the lungs, which is mimicking the effect of what epinephrine or norepinephrine would do in the case of a fight or flight, which makes sense. Because if you're trying to run away from a predator, you want as much blood flow to the lungs as possible, and as much, and you want the airways, the bronchi, which is what they're called, you want the bronchi to be dilated, because you want as much air to get in as possible, because you need that oxygen to run, because you're running from a freaking tiger. So this is just a good example. It's a really nice way to kind of start it off. So albuterol is a beta 2 agonist, which means it will dilate the lungs, which is mimicking the effect of epinephrine and norepinephrine. Now that we know that, we can go into the next 2 classes of medications. So, let's talk about beta blockers. So, beta blockers are also called beta antagonists, because remember, antagonists are blocking. So what they do is, let's get our cardiac tissue again. This is just the cardiac tissue cell wall. Or not cell wall, cell membrane, sorry. So let's say this is a beta receptor. So this is a pretty simple, once again, it's all about agonists and antagonists. So normally instead of saying epinephrine and norepinephrine every time, I'm going to say epi or any. These two would normally bind here to a, in this case, a beta receptor on the cardiac tissue. And this would cause increased heart rate increased force of contractions, which both of these would increase blood pressure because you're pumping more and pumping harder. And that's what epinephrine and norepinephrine want to do. They want you to get more blood around so you can fight the tigers or whatever. But this is kind of a problem because like we don't always want to have high blood pressure, and so what we do is a beta antagonist will go and once again, it's going to take up that space, it's going to block the receptor, and it will not mimic the effect of increasing blood pressure or increasing the contractility of the heart. It's going to stop that and block norepinephrine and epinephrine from binding. The most important thing is it slows the heart. So like sometimes you can see in research that I've done at my university, you'll see like people on beta blockers, they can work out and their heart rate will like reach like a natural maximum. Like it just like hits a wall because they're on beta blockers. So no amount of epinephrine and norepinephrine is going to change that, which is really interesting. And so common beta blockers are going to be things like metoprolol, which is also called toprol. Let's see here. We have propranolol, which is called Inderol. We have atenolol, which is called Tenormin. And we also have bisoprolol. And for all of these classes, there are more medications. I'm just giving the ones that you will see the most, because if I tried to show you every single medication, I'd go crazy. There's a lot. So as you can see, the common ending for beta blockers is metoprolol, propranolol, atenolol, and bisoprolol. And so there's two things I want to mention here. So one, this is really important for metoprolol. I want you to remember this. So metoprolol has two forms. There is succinate and tartrate. So metoprolol comes in these two different, they're called salt forms because it's like the same ingredient but different formulation, and it's very important to know the difference between these because in pharmacy these are one of the most common sources for med errors is metoprolol. So succinate is long acting and tartrate is short acting. So for succinate, you'll probably take this one once a day, so QD. Tartrate, you can see people who take it like BID or TID. So 2 times a day, 3 times a day. But it's very important that you don't get these mixed up. So you always want to check when you're pulling a metoprolol bottle or pills to be dispensed. Always make sure, always check with the salt form, because it's really important that they get the correct one. You don't want someone like who takes tartrate to suddenly accidentally take 3 succinate tablets. That's way too much metoprolol, and then you could you could totally inhibit contraction of the heart, and that's really bad. We don't want to harm our patients, you know. And so a really good way to remember the difference between succinate and tartrate is I think so you slowly, that's a tongue, by the way, can you believe that? You slowly suck on a lollipop, whereas something that's tart, you want to get out of your mouth ASAP. So suck, so you suck on a lollipop for a long time. And then tartrate, you want to get whatever, you know, you don't like something tart in your mouth, so you want to get it out. So it's short, you know, it's not in there for long. So this is really useful. I always think like, oh yeah, I suck on a lollipop for a long time, you know, it's a slow. So, succinate is, you know, like I said, it's the long acting, which also means it's going to be called something like XL. So like extra long or slow release, something like that. Whereas tartrate will just be called metoprolol tartrate. So yeah, it's something really good to know. And also something good to know about propranolol is also used for anxiety. In fact, I feel like I see it more for anxiety than blood pressure. Because even though this is a beta blocker, remember it's working all across the system. So it may also slow the heart, but it can do other things to, you know, help relax you, because I mean, even slowing your heart just relaxes you. So these medications can be used in various ways. You're going to see a lot of overlap, a lot of medications, especially ones that act in this adrenergic system. You're going to see multiple uses for them because they affect, there's such systemic effects, which means that, you know, one effect can have such a huge change across the body. And so on the other side, we have alpha-1 blockers. So once again, alpha receptors are bound by epi and norepi. So, but the difference here is that alpha-1, these receptors are mainly going to be found in, oh, that's the highlighter, that's silly. They're mainly going to be found in the blood vessels. So let's say that these are the, you know, the two walls of the blood vessel. So and so once again, let's say that we have some epi here, and when it binds to this blood vessel's alpha-1 receptor, remember that alpha contracts or constricts. So normally epinephrine is going to bind to that alpha receptor, and it's going to cause the walls to, kind of close in on each other and constrict. The more proper term is vasoconstriction, which makes sense because vaso means vessel, and constriction is like closing, something like that. And so we actually do this because epinephrine does this because when you reduce the diameter of those vessels, it's going to increase blood pressure, which means more blood is going to get back to the heart, because it goes along faster. It's going faster to the heart, more flow. I think of it like a low pressure hose versus a high pressure hose. It's kind of sort of similar, but not really. So alpha 1 blockers are, once again, they are antagonists. So they're going to come in here and boom. And they're going to block the alpha 1 receptor, which means that the vessel cannot constrict, and so blood pressure is not going to increase. And so this also means less resistance on the blood vessels, because I think of like trying to sip a milkshake through a small straw versus a big straw. It's way easier to have things flow through a larger diameter hole. So it's going to decrease resistance and decrease the pressure because we keep that vessel dilated. So let's just talk about some common let's talk about some common alpha 1 some common alpha 1 blockers are going to be things like prazosin, if I could spell, doxazosin, and terazosin. Prazosin is also called mini-press. Doxazosin is also called Cardura. And terazosin is also called Hytrin. I've never known how to pronounce that. So as you can see, sometimes it will end in zosin. There are other alpha 1 blockers that I didn't mention. These are the main ones you're going to see, though. And so, there's also, so these medications can be used for various things. There's a lot of uses for them. You'll see people come in for all different reasons because these alpha and beta receptors are everywhere around your body, and they all do different things in different places, and they also have different densities. So some receptors you won't find at all in certain places, or very little. So alpha 1 receptors are the highest density of them is found in your vasculature or your blood vessels. And finally, we have our diuretics. So all of these work on the urinary system. To increase elimination of water and sodium. They just do them in slightly different ways. And I don't think I'll go into the in-depths of how they work, just because diuretics can be pretty complicated, just because the kidneys are really complicated. But I highly recommend, if you ever want to, definitely watch videos on how the kidneys work. It's an absolutely amazing process. It's like almost awe-inspiring. So they just work in slightly different ways. So basically, loop diuretics, these will reduce reabsorption of sodium and water in the nephron. So the nephron is the functional unit of the kidney. So you have like millions of nephrons. They're just like small tubes that do a bunch of different stuff. And there's all different, sections of the nephron. But I'm not going to go into that for the point of this video. And then thiazides, they do the same thing. But in a different place. Of the nephron. One important thing is that not just sodium, but also chloride. So that is just important to know, that it's not just affecting sodium, it's also affecting chloride. And finally, you have what are called potassium sparing. And these ones are set apart because with these other two, you can lose potassium over time. Because basically the loop and thiazide diuretics are getting rid of all of your electrolytes, and your electrolytes are all your ions. So calcium, sodium, potassium. I'm sure there's others that I'm forgetting right now. But this can be really bad because potassium is really essential for everything in your body to function. So potassium-sparing diuretics, potassium-sparing diuretics, they inhibit reabsorption of Na, or sodium, but not potassium. This does mean, though, that you could also have a problem where you have too little sodium but too much potassium, which can happen on potassium-sparing diuretics. And I'm not going to go into the specifics of where these things are working, because I just don't think that falls in the purview of this, where it's just an introduction just for entry-level pharmacy technicians. I don't think you need to know that. I just wanted to introduce you to how they work. But basically, removing fluid, removing sodium and H2O means that you have less blood volume. Because that's what the urinary system really is for. It's for long-term control of blood pressure. Like say you just ate a bunch of salt and you drank a ton of water, you're going to start peeing a lot because your blood pressure gets too high. And your body wants to fix that because high blood pressure is not always good in the moment. Like there's a time and a place, So all of these do the same thing of removing sodium and H2O in just different ways, and they have different side effects. But less blood volume, got a ton of blood volume, and now you have less, which means it's easier on the vessels, because like I said, I think of, this is like a high flow water hose, and then this is like low flow. And so it's easier on the vessels and the walls of your vasculature, and it reduces the pressure within them. And not just blood pressure, but also like things like edema, which is where you just have too much fluid. Because when you eat a lot of salt and your body's not working as well as it should, that's going to start causing water to just accumulate in your your like interstitial fluid, and that's really bad. So diuretics. That's why. So since it's all about sodium and water, diuretics are often called the water pill. In fact, most of the time, that's what your patients are going to call it. So I would never say to a patient, "Oh, do you take any diuretics?" I say, "Do you take any water pill?" It's much more, it's a good patient interaction little pearl there. So then some common loop diuretics are going to be things like furosemide, which is Lasix, bumetanide, which is Bumex, and torsemide, which is Demodex. And commonly they can end in "ide," but that's not always. That's just for these. Furosemide is definitely going to be the most common one you see. Probably, one of the most common water pills out there. For thiazide diuretics, these are things like, this is a big word, I'm going to break this up for you. Hydrochlorothiazide. Okay. So hydrochlorothiazide. Which is also, it's often, you're going to see it, because nobody wants to write this out all the time, you're going to see it abbreviated to HCTZ. There's also chlorthalidone and metolazone. And so hydrochlorothiazide, brand name is Microzide. Chlorthalidone is Thalitone. And metolazone is Zeroxolin. So there's no really common ending, but by far, hydrochlorothiazide and chlorthalidone are going to be the most common you see. Hydrochlorothiazide especially, because it's so cheap. It's like a few cents or something. It's so cheap to get hydrochlorothiazide. So it's one of the most popular medications we dispense. And finally, potassium-sparing diuretics. So these are going to be things like amiloride, which is called Mitamor, or Metamor, I never know. Spironolactone, or aldactone, and triamterene. Or diuranium. So nothing super much to say about this, except for spironolactone. It is used as a diuretic, but it can be used for tons of things. Some of its effects, like it can be used for like hormone replacement therapies, like in conjunction with, for transgender patients, which is really good to know. I've seen that used. What else? And I think for just all of these, all diuretics, it is very common to see diuretics used in conjunction with ACEs, ACE inhibitors, ARBs, or like beta or alpha blockers, because diuretics are so kind of in their own category, especially because they deal with fluid management. So it's not just blood pressure. So often you'll see, something like there's a lot of combo pills. So triamterene and hydrochlorothiazide can meet together, which are a thiazide and a potassium sparing. Or you'll see like lisinopril and hydrochlorothiazide. So remember that because this ends in pril, it's an ACE inhibitor. And then this is a diuretic. So, we attack hypertension and fluid from multiple angles. So you'll see a lot of these like combo medications. So there's a lot more to learn about, blood pressure management. But this is just like kind of an introduction. I just kind of wanted to give you an idea of, what you're working with. And I hope this helped at all. If you have any questions, I'd be happy to answer them. I've been a pharmacy tech for, 1 year now. So and now I'm in inpatient pharmacy. So if you ever have any questions about, inpatient pharmacy or anything like that, I would be happy to answer it. All right. Thank you and have a good day.